Ma'am, can you just start sharing the screen, ma'am? Is it right?
Yeah, just give me a minute.
Yes, ma'am. Video on this.
Can you see this?
Yes, ma'am, it is visible. Can you just
Okay.
put the slideshow mode, ma'am, and go to subsequent.
Yeah, I could just.
Still not in the slideshow mode, ma'am.
Yeah, I'll just. Can you see that now?
Yes, ma'am, it's fine. Can you just go to the second slide, ma'am? Yes, ma'am.
Okay.
Fine, ma'am.
Yeah.
Thank you, ma'am.
Good afternoon. Hello.
Just one more minute, ma'am.
Yeah. I just wanted to confirm.
Ma'am, shall we start, ma'am? Chandra ma'am? Good afternoon, everyone. Today, in the series of lectures on neuropsychiatric disorders, we have with us Professor Deepti Vibha, who is Professor of Neurology in AIIMS Delhi. Madam will be taking up the topic on autoimmune encephalitis. This is the second topic for Madam. And thank you very much, Madam, for your continued association in this series of lectures for the past 3 years. Thank you very much for your association and welcome you all. Over to you, Madam.
Thank you, Dr. Ravi, for providing me an opportunity to, share some thoughts on this, again, very important borderline between neurology and psychiatry, and also a topic which is very close to my heart. Also because, it has a treatable and a very rewarding outcome. So in a neurology, when we conventionally say, a lot of diseases in which there are profound problems, but they don't get very well. This is one particular diagnosis where you can change the life of the patient. So I'll be talking about autoimmune encephalitis. And let me refer to this book, which was semi-autobiographical by with the title of Brain on Fire. And it was obviously a very exciting topic, so much so that later on it was made into a movie about 3 years later. And this tells you about the journey about a patient who has autoimmune encephalitis. So if any one of you is interested in seeing or knowing more about autoimmune encephalitis from the layman perspective, I think I would recommend you to watch this once. Now, how I'll go about it is basically I'll talking about the mechanism of autoimmune encephalitis, the types, the investigations that help us in diagnosis. And finally, as neurologists, we are very interested in making the patient all right, as in any other medical discipline. So we'll talk about the easy management and then not so easy and the very difficult management. So we have had a situation where patients have been very easy to treat and are in our follow-up, but we have also had experiences in which in the best of treatment, the patient did not improve the way we wanted them to be. So there's this whole spectrum which is there in the diagnosis as well as in the treatment of these patients. When we look into the history of autoimmune encephalitis diagnosis, it is not a new disease. If you can see the timeline which I've taken from this paper, we started off not actually with the name of autoimmune encephalitis, but with the another nomenclature, which was paraneoplastic. So there were antibodies, and associated with that, there were neurobehavioral problems as well as manifestations which were neurological, but remotely related to an autoimmune disease. So anti-yo, anti-hu, anti-re are familiar terms which were there with us in the 1980s also, but they were associated basically with neurological manifestations and underlying malignancies. Later on, it was only in this 2005 to 10 decade that we got onto cellular antibodies like NMDA and VGKC, which changed the entire paradigm of the diagnostic as well as management of these patients. So if you look at the mechanism of autoimmune encephalitis, you can have it with the antibodies which are against the synaptic surface proteins, which are very much different from the intracellular cytoplasmic onconeural antigens, which were there earlier detected before the era of autoimmune encephalitis associated with NMDA, LGI1, and AMPA related proteins, which are basically the basic differences that they are synaptic surface proteins, whereas the paraneoplastic ones are basically intracellular cytoplasmic. Another subset, by the way, which we, amongst the autoimmune encephalitis also, by which we kind of segregate the mechanism of AE is by the antibodies. So anti-NMDA antibodies bind to the extracellular unit of NMDA and reduce the NMDA density by cross-linking and internalizing these receptors. So there are less, and then that leads to neurological manifestations. whereas more like GABA and anti-glycine receptors act through blocking receptors and preventing the neurotransmitter binding to the receptor. So these are the two mechanisms by which the cellular mechanisms act and lead to clinical manifestations. There can also be disruption of channel opening and blocking function of supporting proteins, as happens in Casper and DDPX. And there can be intracellular synaptic proteins, in which there are two mechanisms. One is via the cytotoxic T cell, and the second is via the enzyme-mediated glutamate decarboxylase, which helps in internalization of these receptors and vesicle fusion. So because of this, they are no longer active and the patient develops symptoms. So because of this neurotransmitter problems, there would be varied presentations. And as you can see in this very interesting diagram, that you can, depending upon the frequency, so NMDA, LGI1, GABA, they are most frequent, whereas Iglon 5, DPPX, AMPA, these are least frequent. But so there are several ways in which we can classify how these present. There can be anatomical classification, there can be the biomarker based presentation, and you can also remember it based on which presents in young age. More simpler, because patients don't come with a label, they come with symptoms. So I usually recommend that we should start with the way the clinical presentation or the clinical profile of these patients is, whether they are presenting predominantly with seizures, whether they are presenting predominantly with psychiatric disturbances or with cognitive decline, because they will help you in delineating which particular antibody you should look out for in your armamentarium of a big platter of antibodies that you now have. So another way of classifying it would be, based on age. So MOG and NMDA most commonly present in young age. Then GABA and glycine can present in a broad range of ages. And then in elderly, of Iglon 5, GABA, Casper, AMPA, DPPX. So based on this also, you can keep on classifying the diseases. Another interesting way is, as I told you, which neuropsychiatric features are there. So if autonomic dysfunction is there, think about NMDA. If seizures and status are the predominant symptoms, then think about GABA and AMPA. If the patient presenting to a typical fatiobrachial dystonic seizures, then LGI1 would be a possibility. Similarly, if the predominant features are myoclonus, tremors, and diarrhea, although uncommon, if diarrhea is present, then that points out towards DPPX. Peripheral nerve hyperexcitability syndromes are present with Casper too. Optic neuritis and myelitis we know are associated with MOG, and a syndrome of progressive encephalopathy with rigidity and myoclonus limbic encephalitis, which is abbreviated as PERM, is associated with glycine receptors. Similarly, if there are sleep disorders, parasomnia, sleep apneas, they can be associated with Iglon 5. So this would be another way of distinguishing which type of autoimmune encephalitis you are dealing with, depending upon the predominant clinical feature. This might look simple, but this is kind of an oversimplification, I would say, because there is a lot of overlap. It is the dominant symptom, but it might so happen the person with seizures might also have associated autonomic dysfunction and peripheral nerve hyperexcitability. So combination of features can also present, and sometimes in those cases it might be difficult to classify, and therefore the serological classification is also something which helps us to give a label, a proper label to the diagnosis. This can give us a syndromic thing, but this will give us a label to the diagnosis. So as I alluded earlier in my earlier slides also, that we can classify it in several ways, and that probably makes the syndrome of autoimmune encephalitis even a little more complex. So depending upon the anatomy, where is the lesion predominantly in the brain, whether it is a limbic system, whether it is a cortical or subcortical structures, whether it is the striatum presenting with movement disorders, whether it is diencephalon, whether it is the brainstem, the cerebellum, whether it is a combination of brain with cord involvement like happens in MOG, or whether it is presenting predominantly with meningoencephalitis. And as I told you, sometimes it can be combined. It can start from the limbic system and go on to the striatal system, or it can start in the striatal system and go on to the brainstem. And depending upon where it has started, it will give us a clue to the underlying diagnosis. However, having said that, a lot of times, as I told you, there can be a clinical overlap. And therefore, once we get a serological evidence, that is where we can clinch the diagnosis and we give a label to the diagnosis. So there can be onconeural antibodies related biomarkers, which can be positives, anti-U, anti-MA, anti-RE. Similarly, there can be antibodies to surface antigens, classically NMDA, AMPA, LGI1, Casper2. And we had talked about this list, and we will keep on coming back to the list back and forth as we go to various syndromes and their management later on. And the antibodies to surface antigens like VGKC. And of course, we have this group of seronegative autoimmune encephalitis. So when it is seronegative, then how can we say it is autoimmune encephalitis? Why is it not viral encephalitis? Why is it not, any virus which we have not been able to isolate by whatever best tests we could do? And then why is it autoimmune and why not infective? To argue over that, there are a pathophysiological mechanism which also says that there is a system of molecular mimicry. So all these antibodies to this particular, substrates like NMDA, AMPA, or Casper or GABA, they are all receptors and the biochemicals. So it is said that the infection triggers the generation of these antibodies, and later on it becomes a self-perpetuating process. Having said that, we also know that this list of autoantibodies is growing every year, every day. So the group of seronegative autoimmune encephalitis may keep on shrinking over time as we see that the number of identified antibodies become more and more. So in the era of 2006 to 2015, let's say we had only 5 names. Now we have 10 names. In the next 10 years, 10 more names might come. So this might make the group of seronegative autoimmune encephalitis even smaller. Having said that, the big panel of all these, as this panel goes on getting bigger, the costs also increases. So therefore, knowing the anatomical as well as the clinical sometimes saves us from doing a lot of these panel-based tests and thus adding to the cost of the patient. Okay, so a lot of times, MRI might show you classical bilateral mesial temporal hyperintensities and make your job easy. But recently we've realized a very good role of PET in the detection of autoimmune encephalitis, especially like if you can see in this diagram, the FDG PET in LGI1 autoimmune encephalitis shows us classically that there is increased uptake in the basal ganglia. This is the control, this is the normal, and this is in LGI1. And it can show that there is unilateral increase uptake, whereas here, so there can be asymmetry also. And in the basal ganglia also, again, there can be increased uptake. So this can help us with the diagnosis, especially in seronegative. And not only can it help us in the diagnosis, it can also help us in looking at how efficacious is our management. So before the treatment, you can have increased uptake, and with treatment, you can have a resolution of this uptake findings in the PET. Having said that, PET is an investigation which we mostly reserve for patients in whom the imaging is normal, as well as there is seronegative autoimmune encephalitis. So in those cases, FDG PET can help us. PET is also not available everywhere. And if PET is available and indicated in a subset of patients who are seronegative, in which there is a high index of suspicion of autoimmune encephalitis, but there is no antibody which you get positive, and you want to start immunotherapy in these patients, then this gives you a good evidence that you can go ahead and start immunological therapy, especially if the CSF is negative or not contributory. So this again shows you the PET images. So one thing important in all these studies is that not only can it help us in delineating the type of autoimmune encephalitis, it can also tell us the topography. We talked about the anatomical classification. So we can see that in VGKC related, there can be, hello? Can you hear me? Yeah, so there can be increased uptake in the basal ganglia structures, whereas in GABA, there will be increased uptake in the mesial temporal lobe. So this way you can get a little bit of hint as to what is the type of non-onconeural antibodies. So in limbic encephalitis, imaging has been reported to typically reveal mesial temporal lobe hypermetabolism, even if MRI is negative or inconclusive, suggesting that it could be more suggestive, more sensitive than MRI. So our usual dictum is that we see a patient, we suspect that there could be autoimmune encephalitis or post-viral encephalitis, as we'll be discussing about the differentials later. The next step is to establish that diagnosis, right, before we start immunotherapy. The first step is to do a brain imaging to exclude any structural lesion. So in that case, if the MRI is normal and it is non-contributory, then CSF can help us, then the serological tests, and in thereafter, we can get the help of the PET imaging as well. So we understand that the diagnosis of autoimmune encephalitis in itself might sometimes become challenging. And in such cases, there is now a role of, based on these evolution of all these diagnostic tools over a period from 2005 to 2020, and still the increasing number of tests and armamentarium that we are having, there in 2021, there was publication of a diagnostic criteria for autoimmune encephalitis, in which the diagnosis can be made when all three of the following criteria have been met. So it basically assembles all the things that we have just talked about, but structures it in a way so that our diagnostic yield should be high. So the first is clinical, as I told you. It should be subacute onset, rapid progression of less than 3 months of working memory deficits, and altered mental state or psychiatric symptoms. In addition to that, so short-term rapid progression of clinical symptoms, and in addition to that, at least one of the following in the form of new focal CNS findings, seizures which are not explained by a previously known seizure disorder, CSF pleocytosis. It should not be in thousands, but it should be around, like the normal CSF count is also something which you don't see. So that is, if we are seeing some pleocytosis, that goes in favor of autoimmune encephalitis. And if we see MRI features suggestive of encephalitis, especially bilateral mesial temporal lobe hyperintensity, bilateral white matter hyperintensity, that goes in favor, and a reasonable exclusion of alternative causes. Now, this looks like a very simple and small criteria, but when you look at the exclusion of alternative clauses, the third thing, which you, the last line on the bullet that you see, then it opens a Pandora's box, because what you have there is a big list of causes that you need to exclude. And that sometimes leaves us in a quandary as to what all should we do to exclude this. So we know that, all that should be excluded as a big list of differential diagnoses which can mimic autoimmune encephalitis, namely the CNS infections, most important being herpes encephalitis, septic encephalopathy, because patients with fever and altered sensorium can also be having a focus of fever and infective focus, metabolic encephalopathy, drug toxicity, especially brainstem stroke, so cerebrovascular disease, primary CNS vasculitis can be a big mimicker, neoplastic disorders, especially primary CNS lymphoma and lymphomatous disorders, or leptomeningeal carcinomatosis can be a huge mimicker of these symptoms. Creutzfeldt-Jakob disease, because they also have temporal involvement and striatal involvement, so they can be a very close differential, and they can present with rapidly progressive cognitive decline with seizures. Epileptic disorders, rheumatological disorders, so secondary autoimmune diseases with neuropsychiatric features, especially CNS lupus, Kleine-Levin syndrome, Reye syndrome in children, mitochondrial diseases, and inborn errors of metabolism, especially in children. So how do we approach? So step one is that we establish that there is a focal or multifocal brain pathology suggestive of autoimmune encephalitis. Then we do a brain MRI, we do an EEG, we do a PET, depending upon what we get in each of these investigations. And if we get a classical delta brush, if we get, bilateral mesial temporal hyperintensities, then we need not go with more exotic investigations. And these investigations are also listed on the top in that diagnostic panel because they're essentially non-invasive. Step 2 would be the confirmation of this diagnosis and ruling out differentials. I gave you a big list of differential diagnoses that can be there in these patients. So this can be helpful in excluding other diagnoses, and of course also giving a label to the diagnosis. So second step would be that you would do a lumbar puncture CSF, and then you would do neuronal antibodies as well as CSF neuronal antibodies. So paired CSF and serum can be more confirmatory. Obviously, it adds to the cost. And sometimes if you are not able to do a lumbar puncture for some reason, you should at least send the serum neuronal antibodies if there's a high index of suspicion, so that if they come positive, then you can start definitive treatment. And then, of course, the last step is to, especially if you're thinking of an underlying a malignancy as a cause of manifestation of this symptom, then you should do a CT chest abdomen, a mammogram, an ultrasound, and also a whole body PET along with the brain PET, which you are doing anyway to classify the autoimmune encephalitis. So once you do all this thing, then you would wonder when will you start the treatment, because all this is going to take time. The way we do it is that if there is a high index of clinical suspicion, if the MRI is able to give us a go ahead that this could be autoimmune encephalitis, and the CSF is showing you pleocytosis with mildly raised proteins and normal sugar, then you are more or less certain that you might be right in your diagnosis of autoimmune encephalitis. Reports of neuronal antibodies might take a few time depending upon the center where you are working, if it is in-house available, or you are sending it outside, and then it might take more time. But if all this is clean, then you can actually start the patient on a dose of pulse steroid and look for clinical response, especially in a lot of seronegative patients in whom there was a high index of suspicion. We have seen it very rewarding that the only way that we could suspect or see that it was indeed autoimmune encephalitis was a magical response after pulse steroid treatment. And also sometimes when the clinical suspicion is of CJD and EEG is not showing us the typical 1 Hz spike wave discharges, there have been situations when they've responded very nicely to steroid and immunotherapy, and then people had to revise the diagnosis. So that is one clinical scenario where you go from an irreversible or incurable disease to a curable disease. Now, having said that, there can also be a big subset where you can actually misdiagnose autoimmune encephalitis because of this big inundation of the list of the things that we have just talked about, starting from NMDA, which was reported in 2005. A lot of people have, because it is treatable, you don't want the patient to give the first label of an autoimmune encephalitis of a CJD or of a degenerative disorder. You end up giving a trial of steroid, and it is only over evolution over a period of time that you see that indeed it was a non-treatable or a degenerative disorder that you were dealing with. Sometimes our threshold also becomes very low for treating these patients, and later on we come to know that there was a functional neurological disorder associated. So this was a very interesting paper which was published in JAMA Neurology in 2023. So it is recent, which looked at the cohort of patients in whom the initial diagnosis was autoimmune encephalitis, but the eventual diagnosis turned out to be one of the alternative diagnoses. And they have listed this, and this is again, if you look at it closely, it was basically all the differential diagnoses that we are supposed to exclude. So it was basically the neurodegenerative dementias, especially the CJD, which was out of 2 patients who had this autoimmune encephalitis as the initial diagnosis. one turned out individuals who fulfilled the possible criteria of autoimmune encephalitis and were treated like that, they eventually had the diagnosis of CJD. Similarly, patients with psychiatric disorders like depression, anxiety, schizophrenia can also mimic autoimmune encephalitis. The other big differential was, of course, gliomatosis cerebri, primary CNS lymphoma, and some posterior fossa malignancies. Then seizure disorder, which were non-autoimmune mediated. Then residue of viral encephalitis. Sometimes there is progression only because there can be recurrent seizures, and if they are not treated well, then then it might look like a pseudo progression. Once you treat the seizures, then the patient stabilizes, and then you know that probably this is only a sequel of viral encephalitis and not an ongoing autoimmune encephalitis. Similarly, if we skip the steps, like I told you, in clinical medicine, if whenever we skip the steps, we land up in trouble. We give patients steroid because we have a high index of suspicion of this patient having autoimmune encephalitis, and we don't send a simple HIV serology, and then we end up in a problem because we have not sent that in the first place. So other metabolic diseases like adrenal insufficiency, we talked last class about Wernicke's encephalopathy, and they can also present like rapidly progressive cognitive decline with various neurobehavioral features, and they can also have seizures. So in such a situation, if you don't take a proper history, and if you don't suspect that it could be all because of thiamine deficiency, then you might miss the diagnosis and unnecessarily give the patient steroid, which might be detrimental to that patient. And of course, I told you that sometimes small vessel vasculitis, Kleine-Levin syndrome, and multiple sclerosis with associated depression. So all these can mimic autoimmune encephalitis, and this was a nice series which was published from the Mayo Clinic. So this also gives us a list of alternative diagnoses which we should always suspect in a patient in whom we are not finding improvement after an adequate immunotherapy. We should always step back, go back to the history, examination, the investigations that we have done, and look for alternative diagnosis in such patients before embarking on second generation treatment or a more aggressive treatment. So what is the general management? Basically, the general management revolves around searching for the underlying tumor, because if we get that, so in NMDA encephalitis, if we get a teratoma, then we are happy, because if we treat the ovarian teratoma, then the outcome of these patients is going to be very good. Similarly, if we see thymoma, or we are able to detect thymoma in a patient with Casper-2 and autoimmune encephalitis, then we know that once this thymoma is taken out, then this patient is going to have a good outcome. So neurological symptoms will precede tumor detection. So what happens if you find that it is NMDA positive and you treat the patient? You should keep on doing serial screening so that if the tumor comes up later, it is not left undetected and you are able to manage it. So if a tumor is not detected in the initial screening, we should repeat imaging 6 monthly, at least for an interval of 4 years. We had one patient who had limbic encephalitis and turned out to be anti-U positive. So we thought that it is paraneoplastic related. However, her serial PET imaging for probably the past 3 years have been negative. And we have also been repeating her paraneoplastic antibodies to see if they have ebbed down or they have become negative over a period of time. She is still on immunosuppressant, and otherwise she is stable, but anti-U is repeatedly positive for the past 3 years. So we can get a few such subset of patients in whom we are not able to detect any tumor. So we should not give up. 4 years is again arbitrary. It's a matter of time that we will get a publication where the tumor could have been detected a little later. Of course, the debate would be that, we would end up over-investigating and over-investing on these patients and putting a lot of expenditure on repeated PET imaging as well as antibody monitoring. But remember that a malignancy treatment is completely different. It requires resection of the underlying tumor. And therefore, doing it once in 6 months or a year might not be, might be, actually indicated in a patient who is presented with limbic encephalitis. So that is something which you have to be knowing. And similarly, symptomatic management of seizures, symptomatic management of dystonia, if the patient is having that, behavioral and mood disorders sometimes do require urgent and symptomatic treatment. Sleep disorders will again require symptomatic treatment. And autonomic disturbances, especially if the patient is having severe orthostatic hypotension, or the patient is having symptoms suggestive of diabetes insipidus, then they need to be symptomatically managed. So NMDA antibody-related encephalitis have hypersensitivity to neuroleptin agents and a risk of neuroleptin malignant syndrome. So this should be known to you, because if you are managing such a patient and the patient is having a lot of psychiatric features, and if the patient is NMDA positive, then you should spare yourself from giving the typical neuroleptic agents. Similarly, LGI1 antibody encephalitis seizures is better controlled by immunotherapy than with anti-seizure medications. So this is also very important, because you keep on loading the patient with 3, 4, 5 anti-seizure medications. But if you delay on the immunotherapy, these patients will behave like drug refractory epilepsy, and then you will be struggling with their medications, and later on with the side effects of having several anti-seizure medications which the patient would be on. So if you fail to detect LGI1 and the patient indeed has, so there is a delay in that diagnosis, and patient is just presenting like NORS or fires, new onset status epilepticus, and you don't do this, and you keep on giving the patient a lot of anti-seizure medications, and they might land in more problems based on the number of anti-seizure medications that they have been taking. And it is better to treat these patients with immunotherapy. Then again, in LGI1 related antibodies, it has been shown that there's a higher risk of cutaneous reaction in Stevens-Johnson syndrome. So not only do the anti-seizure medications add to side effects, they can also potentially lead to life-threatening problems also. So some of the same is true for seizures associated with multiple forms of autoimmune encephalitis, that they respond better to immunotherapy. Then in LGI1 body encephalitis, 80% of the patients have faciobrachial dystonic seizures, which are very typical, and they precede the onset of cognitive impairment. And in NMDA encephalitis, early treatment is independent predictor of good outcome, whereas delay in immunotherapy for more than 4 weeks is associated with poor functional outcomes. So this knowledge is important, because if we keep on waiting for the investigation reports, and sometimes there is a delay in the clinical diagnosis also, that you don't even suspect, you feel that this patient is having a psychiatric disorder, and this patient does not need to go to a neurologist, or the other way around, the patient is with a general physician, and they send the patient, they spend another 2 weeks, 3 weeks just giving symptomatic treatment, and after that they feel that the patient is not getting any better, and then they say, let me now refer this patient to a psychiatrist, because all the symptoms are related to psychiatry, and it is only after a flurry of seizures that the neurologist comes in, and then the diagnosis is thought of after the first seizure that it is NMDA antibody receptor mediated encephalitis. Then the treatment is already delayed, and that leads to poor functional outcome in these patients. So early immunotherapy improves outcomes. This is a brief algorithm based on basically you can have various ways of forking it out, as I would say, based on clinical. But here, this particular consensus paper, which was there in 2021, along with the diagnostic criteria, it has laid down this. I will subsequently show you another flowchart, which I also like. So this is basically if you get a paraneoplastic, if the tumor is present or not. More often than not, we keep on searching for the tumor, we don't find one. So I think this part of the algorithm is more relevant for us neurologists. If the tumor is present, then the job is made easy. You resect the tumor, you give immunotherapy, and then you keep on following the patient. And if there is no tumor present, then still based on the diagnostic criteria, even if there is no serological marker, if you're a serological marker, then you are lucky. Then you give methylprednisolone, IVIG, or Plex, And then if there is much improvement with that, then you keep the patient on immunotherapy and steroid sparing agent. If there is no improvement with that, you go ahead and escalate it to rituximab. And then if there is no improvement with that also, then you can give IL-6 inhibitors or bortezomib. So that is in short about how we go about it. But you would wonder, when would we think after giving steroid that this patient is not responding, and then we should start giving rituximab? So should, on the 5th day, if the patient has not improved, should we start rituximab on the 6th day? Should we wait for 1 month? Should we wait for 2 months? So how long are we supposed to wait for the response to happen? So we'll get to that. Usually the dose, before I get to that, I think this most of you know, but at the cost of revision, I think it is very important that when you give IVIG, you should give 2 gram per kg over 5 days or 400 milligram per kg per day. And plasma exchange should be given alternatively for 5 to 7 cycles. We usually give it for 5 days. Rituximab infusion, we give 375 milligram per meter square weekly for 4 weeks. One of the preferred regimes is also giving giving a cumulative dose of 1 gram for an adult 2 weeks apart. So that is another regime which we follow, and then repeat it 6 monthly. Cyclophosphamide we can give monthly for 3 to 6 months, depending upon the clinical response of the patient. Other treatments, especially azathioprine and mycophenolate, also we use very often in patients with milder disease, in whom the disease stabilizes after giving first-line treatment, and after that we just keep them on azathioprine. So that is again a very popular treatment which we practice. So first-line therapy, it consists of corticosteroids plus IVIG or plasma exchange. There is a debate whether you should wait after steroid or give IVIG along with corticosteroid and with plasma exchange simultaneously. We first prefer plasma exchange because if there is no response with plasma exchange, we still have an option of giving IVIG. We cannot give IVIG, we cannot give plasma exchange soon after IVIG because it will flush out the IVIG from the system. So that is the reason why we follow. The other reason why we follow this regime is also because plasma exchange is cheaper than IVIG. So it is more economical to offer plasma exchange to the patient first. There is no strong evidence of superiority between IVIG and plasma exchange. So they should be actually used based on the availability and cost. What I had just talked about was my institute protocol and our department protocol, and other places might use it differently. And there is not really much evidence of superiority of one over the other. Plasma exchange is more difficult to use in children and in patients who are having dysautonomia. Also in sepsis, IVIG is preferred, and IVIG should not be given. Plasma exchange should be avoided in patients with hypotension, because it might lead to more complications, which might be procedure related. And it should not be, it should be noted that IVIG can be removed by PLEX. So PLEX immediately after IVIG should not be given. I had already talked about this aspect. So when should we switch to second line treatment? So though there's no improvement seen within 2 weeks, but 2 weeks is again arbitrary. Some people give it earlier, some people wait for a little more time. If there has been partial improvement and you feel that the improvement has not come completely, so let me wait for another 1 or 2 weeks. And this is not really based on a very high level evidence, but that is more what most of the experts say, that if there is no improvement in the next 2 weeks, then we switch to second line treatment. Also, when the patient is stable on a first line treatment, so patient is on azathioprine and comes back with a bad relapse, that is the time when we think that azathioprine continuity might not work, and we might have to switch to a better treatment. So that is the time when we give rituximab or cyclophosphamide. And of course, in the beginning also, if we see that there is a severe clinical presentation, the patient is come intubated, the patient is M5, the patient is seizing, and has status epilepticus. So in those patients also, sometimes when we feel that the autoimmune process is very aggressive, the treatment should also be very aggressive. So in such situations also, we sometimes after IVIG or PLEX, we instantly escalate to rituximab and do not wait much. So in NMD encephalitis, the start of second line therapy has been shown to have better outcome and less relapse rate. And due to good tolerance and efficacy, rituximab is now preferred over cyclophosphamide. Cyclophosphamide is still a very old drug and a well-known drug. So, and it is good for patients who have financial constraints and who cannot afford rituximab. It should not be said that you cannot get any treatment. The option of cyclophosphamide is there, and the optimal duration of treatment, how long should you give, is still something which is not very clearly known. Most of the patients in whom we have a 5-year, 10-year follow-up, and whatever the literature also tells us, that there is a likelihood that the symptoms recur or come back once the immunotherapy is de-escalated or stopped. Sometimes patients have stopped them on their own because they felt that they were doing well and they've come back with the relapse. So this is kind of a disease in which the autoimmune process is there for a long time. There is little support for the use of maintenance. Support of the use of maintenance immunotherapy, but it can be used in AE which has a high relapse. So I told you, LGI1 and MDA, they have a high relapse. But we really don't know. This is a disease in evolution, and we might know more and more about the disease conditions over the next 1 or 2 decades. So antibody-mediated autoimmune encephalitis can be monophasic, that is maintenance phase can sometimes be stopped in 1 to 3 years. However, we don't know it very well for, let's say, MOG-related encephalitis, and the evidence is still developing on that. So there are some situations for which the answers are not very clear. Now, this is just a forest plot to show you the effect of rituximab in autoimmune encephalitis. And you can see here that the proportion of patients achieving good outcome are about 77.4%. So it has a good effect on the outcome of patients of autoimmune encephalitis. So 72 point, so obviously this was a confidence level, 72.2% patients had a good functional outcome. So when do you say it's refractory autoimmune encephalitis? We say it's refractory autoimmune encephalitis when it is ineffective to the first line and the second line therapy, first line therapy and the second line therapy. So 19 to 33, so about up to 1/3 of the patients with autoimmune encephalitis do not respond to the first line and second line therapy, and there is persistent neurological and psychological problems. Now, when can they happen? The most common cause is delay in the diagnosis. So if it is diagnosed into a very advanced stage of the diagnosis, then of course you might left with a sequelae, or you might have a patient with a very advanced stage of the disease. Patient might be comatose, patient might be intubated, patient might be having status epilepticus, and then those patients you might not find a very rewarding treatment with first line and second line therapy as well. So in those cases, there has been the role which is still under evolution and still under progress. There are ongoing trials on bortezomib, daratumumab, natalizumab, tocilizumab. There is some building evidence to say that tocilizumab and bortezomib may be given in select few patients of refractory autoimmune encephalitis. And I think I have a little few slides on that just to give you a flavor of what is being done in research. So basically, when we talk about, sorry. So when we talk about tocilizumab, it is a humanized monoclonal antibody against interleukin-6, and that blocks interleukin-6, and it has a pivotal importance in the stimulation of T and B cells. Tocilizumab is a very popular drug after COVID. So everybody knows about it, but it has also been used earlier in rheumatoid arthritis, neuromyelitis optica, and SLE. So the evidence for the treatment of autoimmune encephalitis basically comes from case series and observational studies, but there are ongoing trials on this, and soon we'll get more evidence. So it decreases the, so this is the graph which shows that it has a higher proportion of patients with MRS less than 2 if we give tocilizumab. Similarly, this is again the graph, I think. Then bortezomib, it is a plasma cell which are relatively unaffected by rituximab. So they do not express CD20. And therefore, the rationale of using bortezomib is there in these patients, which has been used earlier in multiple myeloma and NMO. So there are also case series and case reports of the effect of bortezomib in autoimmune encephalitis. So this is another flowchart which I was talking about, and this tells you about the management. So when we suspect a patient with autoimmune encephalitis, the first line immunotherapy that we give is MPS, Plex, and or IVIG in whatever sequence we want to follow. If there is a good response, then but the chances of relapse are high, then we have these patients on maintenance therapy like azathioprine or mycophenolate mofetil. And if there is no or minimal response, then we go on to second line immunotherapy, which is basically rituximab or cyclophosphamide. Now, if there is a good response and there are syndromes in which there is a less chance of relapse, then we can just do a regular follow-up. But if there is a poor response to second line immunotherapy, so if it is refractory autoimmune encephalitis, then we can go on to bortezomib or tocilizumab. Now, before we finish this talk, it is very important to remember that there are syndromes which would just present like drug refractory epilepsy. And in those situations, it is good to know that in autoimmune epilepsy, so autoimmune epilepsy has been another syndrome which has been associated with, again, NMDA and VGKC associated antibodies. So there is a AIP score and a RIGHT score, which helps us in classifying these patients and giving them appropriate treatment. So the diagnosis of autoimmune epilepsy is again based on new onset, rapidly progressive mental changes with neuropsychiatric symptoms with autonomic dysfunction. And we give 1 point for each of these features associated with vilar prodrome, facial dyskinesias, refractory seizures, CSF findings like autoimmune encephalitis, brain MRI showing you C2 flare signals in the temporal lobes and in the limbic system, and the presence of underlying malignancy. So this is the AIP score. And in the RIGHT score, we have additionally 2 more points of initiation of immunotherapy and response to immunotherapy in the first 6 months, and of course detection of any antibody. So if the AIP score is more than or equal to 4, then there is a high sensitivity that this patient might be immune mediated epilepsy, and in those patients steroids would help more than anti-seizure medications, as I told you earlier. And if the RIGHT score is more than equal to 7, then also it carries a high sensitivity of autoimmune epilepsy. So the salient points at the end, which is very, very important after all this discussion, and I think I've been reiterating it from slide 1, that autoimmune encephalitis is a clinical chameleon. So it has various presentations. It can present in the Department of Psychiatry, it can present in the Department of Neurology, it can present to us in the Department of General Medicine, it can present in geriatric clinic, it can present in pediatric clinic. So because the age range from where it happens is from pediatric to geriatric, there's a wide range of age groups where it can present. So it can have various presentations, there can be diagnostic challenges, and especially in seronegative cases, it can be even more challenging. The second important thing is that it is treatable. So if you miss it, then it will be difficult because you will get, you will be missing out on treating a patient who could have a different outcome, and it can change outcomes. And thirdly, and the most important thing is that it has an evolving spectrum. You can get new symptom complexes, you can get new biomarkers, and you can get new radiological findings which we have seen evolving during the past 1 or 2 decades. So it's still a disease in evolution. We might get more knowledge about this disease over the next few years. There's a lot of research going on. So these would be the salient points which you all should know. And thank you for a patient hearing. I think we are almost at time, and I think
Dr. Venu,
to have discussion.
Venu ma'am, can you please mute? Thank you very much, ma'am. Any doubts and discussions, please unmute and you can discuss. Chandra madam, your comments, ma'am.
So there are a few questions in the chat panel. I think I can answer them before there are more questions which the people might want to ask personally. So, what is the maximum number of rituximab doses you've given in one patient? So basically, the way of monitoring rituximab is that we give 2 doses. We give 2 doses. Some institute give 4 doses weekly for 4 weeks and then repeat it at 6 months. Our institute usually gives 2 doses or at a fortnight. So 1 gram IV infusion, today and then maybe 2 weeks later, and then we monitor with the CD19-20 counts after 6 months. Usually, if the patient is clinically stable and the CD19-20 is also like 0% most of the times we get, or less than 1%, then we can reschedule or postpone the dose of next rituximab, but usually give it at 6 months. Maximum dose given, it depends upon how much a person has followed up these patients, because in patients who have a high relapse rate, especially an MDA related, we do give it, and we have been following up these patients for more than 5 years, 10 years now. So during follow-up maintenance, how frequently should we repeat antibody positive case? I don't think you need to repeat antibodies and chase the antibody levels unless we have a quantitative titer and we show that there's a fall in the titer. So there is actually, it's only going to add to cost. The most important thing is clinical remission. One thing which we also do in these patients, coming back to the first question that you talked about, what is the maximum number of rituximab doses? So more often than not, it happens that after 1 or 2 doses of rituximab, the patient, if he or she is very clinically stable, then we can switch to a milder immunosuppressant like isotherapin or mycophenolate. That is also something which we have done in a few patients.
Thank you very much, ma'am.
Okay, CD19-20 for rituximab is a must. Treatment based only on that. Role in MS or MO versus autoimmune encephalitis. Look, the treatment regime of rituximab, whether we are giving it for multiple sclerosis or autoimmune encephalitis or MOG-associated encephalitis is the same. The monitoring is also essentially the same. There are also severity scores of autoimmune encephalitis. There is a case score which was published in Annals of Neurology in 2015. I think we can go through that. I have not included it in this slide for the sake of, there were already too many treatment algorithms and diagnostic algorithms. But depending upon the severity, the patient is clinically stable and you don't feel that you need to escalate the treatment, then sometimes we actually de-escalate the treatment after a few sessions, and that is when we switch to oral immunotherapy. That is also something which we do in multiple sclerosis sometimes, right? Or for that matter in primary CNS vasculitis also. Most of the diseases, autoimmune diseases of the central nervous system.
Hello, that was a nice talk. We have found, and we have also published a series where we found measles antibody elevated as an epiphenomena, and these people are labeled as SSP. So that is, we have a group we have proved, and that was autoimmune encephalitis, but this occurs as an epiphenomena. So we have to be careful about that, fatal to treatable. And this severe panic, I have seen biting patients. So somebody diagnosed as rabies also. They have severe panic, which is a typical feature of rabies. And also they bite themselves and others, and we published it in the Journal of Pediatric Neuroscience. So they are labeled rabies. That means then another person we found that late onset, unusual behavior with fear, short duration. So actually we gathered a group of cases and found panic is an important clue. And we called it as a clinical triad. Asian Journal of Psychiatry we published.
Yeah, so from our department
other
of psychiatry.
neurological manifestation.
Yeah,
Okay.
yeah. So once
Yes.
over the first, I
And
think the
what
last
we
one,
generally follow is 6 months intensive, 3 drugs, then followed by maintenance for 2 years to 5 years is what is generally, as you said, it is all uncertain. We don't know when and what to do. But usually a good number of patients go into a moderate level of recovery after 5 years. We have withdrawn many of them after 5 years and following up. Another small thing, somebody sleeping in a very serious class means better they switch off the video because it will distract the speaker. So that will be nice if the video is switched off and because anyway it is an educative session for us and the speaker should not feel hurt. Then that's a request, switch off when you're sleeping. Okay, that was a very
there
nice
are pros
session.
and
Thank you very
cons
much.
of online sessions. Usually, we get the advantage also that we are remotely placed, but we are still able to attend the session. And of course, there are cons. So thank you, ma'am, for pointing that out. But yes, I would completely agree with you on the part that there are every patient has a different story, and sometimes we find a pattern in a group of patients who have been coming consecutively to us. Like you talked about panic, like you talked about mutilating behavior like biting people and all that. So yes, from our center also, I think the psychiatry department has published over the last 1 decade the collection of patients who initially presented in the psychiatry department but turned out to have autoimmune encephalitis. So now also they have a very low threshold of sending patients with primary and rapidly progressive psychiatric manifestations or presenting as acute psychosis for underlying autoimmune biomarkers, because this has changed the whole paradigm of looking at psychiatric diseases. So the first slide that I showed, that movie of Brain on Fire, that is a very livid example of how the patient can be told, mad or insane, and they might be actually having the disease which can be easily treated with steroids and other immunotreatment. So there are few more questions. IV steroid only enough or plasma or IVIG is a must? This again depends upon how early the disease you've gotten. And if the patient improves completely after 5 doses of pulse steroid, then you can actually give him maintenance steroid and azathioprine if the patient has a very mild disease. I think a few centers and neurologists would be definitely seeing that. However, if you are sitting in a tertiary care center, you have a referral bias. You usually see patients who have been referred from other places because the diagnosis had been missed, or they were not treated early on, or they were more severe in their disease, and therefore we end up giving plasma exchange and IVIG to almost every patient that we admit. That might be the reason, not the other way around, I think. And steroids simultaneously or with so followed consecutive or together. That is again something which we don't have an RCT on, and whether we give it simultaneously or sequentially might more be a thing depending upon the disease severity as well as the logistics and anything else. If you think that the disease is more aggressive, the whole problem is that, if you're giving plasma exchange and if you're also giving steroid, you should be aware that it will wash out. If you give it, you just give IV plasma exchange, and after that you just before that you've given pulse methylprednisolone. So that pharmacokinetics should be known once you are giving it simultaneously, that it should be well spaced out. That thing is important. That thing also first we need to know for sure in the pharmacokinetic drug level monitoring. And the second thing is IVIG along with steroid is something which has been given occasionally in very severe patients. But yes, we don't have an RCT to say that is better than just giving steroids. Ma'am, would you like to add anything to that?
No. Thank you very much. It was very informative and nice talk.
Thank you, ma'am. Thank you, ma'am.
Thank you very much, madam. Any other specific questions or doubts from any other senior faculty? Thank you, ma'am. I think there are no more questions in the chat box also.
Thank you.
Thank you very much. Thank you very much. And thank you all for your. End the session, madam.